Welcome, Beyond listeners. I am your host, Dr. Flora. Welcome to the Beyond podcast. I'm so excited that you guys are here. We have a very special guest. Her name is Dr. Dhivya Srinivasa. She is a double board certified surgeon in general surgery and plastic surgery. In addition to being board certified in both, she has completed a fellowship in microsurgery, which enables her to fully specialize in breast reconstruction following breast cancer and really offer the most advanced approaches to implant and microsurgical procedures. She is the founder of the surgical practice, the Institute of Advanced Breast Reconstruction. Now, this is a practice that gives patients with breast cancer after they've undergone radiation or will be undergoing radiation, really an opportunity to access the proper gold standard for breast reconstruction. Now, in addition to being a total badass in her field, Dr. Dhivya, what catches people's eyes is the fact that Dr. Dhivya is an unapologetic, living, breathing brown Barbie doll whose Instagram page literally says face, fashion, family, and feminism until further notice. End quote. This mama of three has the brains, the sass, skin, fashion, and of course, compassion. Please welcome Dr. Dhivya Srinivasa to the Beyond podcast. Hi, everyone. You are listening to Beyond, and I'm your host, Dr. Flora. Listen, life is hard. You don't have to do it alone. As a mindset coach, physician, mom, and an infertility warrior, I have mastered techniques to help move you towards contentment and growth. I can't wait to go along with this crazy-ass life journey with you while making sure you feel like your best self. This podcast is meant to have you feel unstuck from your rut and less alone. Let's do this. Dhivya, I am so excited that you're here.
Oh, I'm so excited to be here. Also, I got little goosies with that. Thank you so much for that awesome introduction.
Of course, it's all you. I mean, I'm just literally verbalizing everything that you've done and continue to do. I have loved following you on Instagram. Let's rewind a little bit. I work for Cedars-Sinai Medical Group. I'm a primary care doctor there, and I used to work at the Beverly Hills practice. And so I would come across your name every now and then because I obviously would diagnose patients with breast cancer, and your name would kind of come across some of my patients. And then when I found out that you opened up your own private practice, such an amazing resource. My patients love you. And then I found you on Instagram, and it just all kind of came together. So I love following you on there, but I just want to jump right in. Do you have haters? And the reason I want to start with that, because
I do. Don't we all? You know, it's funny when you were giving the intro, and it's like cool to even in the moment think about like, wow, I've done a lot. But then I think about like all my other gal pals, right? You, for example, and just all these women that I know, and everyone is unapologetically doing the most, and I'm here for it. Especially like my brown girls, right? I'm just seeing everyone really take in every opportunity they've been given and doing the entrepreneur thing, social media, fashion, medicine, finance, engineering, beauty, I mean, everything. And it's so cool. And we all have haters. And I think it's because we're just in this weird time, which, haters always existed. They always will. But more than ever, that I almost feel like people are looking to find fault in you. And I think whether that is because of what you believe politically, how you choose to be a mother, how you choose to balance or attempt to balance your work with your life, what you wear, what you say, everything is available to everyone immediately, and therefore everybody feels validated to comment on it. So sure, yes, I have haters. They come in multiple varieties. I think the earliest time that I really felt like I noticed it was when I got pregnant with my first, and general surgery training was, there was just a lot of, oh, why is she doing that? Why is she trying to have a baby now? And it's because because I'm a woman and I want to have a baby. I
Also,
mean,
who gives a fuck? Like, do your thing.
it was so
So pisses
odd
me
to
off.
me that there were so many heavy opinions and people tiptoeing around it, not wanting to say it because at least they had enough insight to know they couldn't just come out and say it. And then it happened again when I had my second kid, and it happened again when I had my third kid. And then I went private, and it was, oh my God, why is she taking the skill that is traditionally academic and moving it to private? Then I got on social media, and all day it's the constant commentary and trying to tear me down. And I always feel grateful because I'm a firstborn, I'm an immigrant. I feel like this is as thick as skin can get. I don't really care, but it makes me sad because I think of other people, like younger women or children
Mhm.
or other people who engage. And I just don't understand when, as society, we all decided that it's okay to attack people on the internet.
Yeah, I mean, you take one look at what you show on social media, and you can automatically tell, like, what you see is what you get. You are so authentic, and that truly can rub people the wrong way. And anytime I see a troll, a comment, a side swipe, like a little dig, it's just a reflection of like that person's insecurity.
Say it again, girl. Say it again.
Y
I mean, that is
Right.
truly, and that's usually what my response is. Stop projecting yourself onto me. If you are insecure about certain things, I'm sorry. I hope that you're able to recover from that, but don't put that on me.
And in the age of social media, it is so easy to be like this keyboard warrior, right? Just go straight to the comments and say, "I don't like it." Well, if you don't like it, why are you here? Like, go, like, leave.
Right.
What prompts you to? But it's this sheer unhappiness, that this insecurity that so many people have, that they need to project that on to someone who's confident, accomplished, and is okay with that, right? And is okay with showing the confidence. I don't know at what point. It just makes me nervous even for our children,
Right.
where I know it's slowly moving away from it. I know Gia, who's 9, she's in the 4th grade. They started their growth mindset curriculum from a very young age. So it's being taught, like things that I
Yeah.
coach on right now, things that I coach my patients, my clients on as full grown adults.
Well,
They're
because we
learning
need
as
it. We
kids.
need that education. We
Exactly.
didn't get it when we were children because nobody could have predicted this is where we would be in 2024.
I know, it's so sad. But that being said, I really do hope our kids are employed with all the tools and techniques that they can utilize. So as their brains grow and develop and become full-fledged adults like us, I hope they can be badasses and be supported by badasses. And whoever can't support that, just stay quiet and like go away.
Right? But I think that's also important that we do these things. That's also why I'm so loud about it on social media because I think when I was pregnant with my first child, if I saw somebody who was 10 years out saying, "Hey, I did it and I made it would have been nice, you
Yeah.
know?" And
Yeah.
so a lot of the positive feedback, the haters, they're always going to be there, but actually the best part of it is the positive feedback, right? When you hear from people on social media that you may have otherwise never connected with saying, "Hey, it really helped me when you said that," or I had a bad day at work and then I saw that video and it was just a 90-second reminder of that this is going to be fine and that I'm going to make it. So
That
it's,
is a great call out. That is a great call. Whether you're on social media or not, whether you're in the public eye or not, and no matter to what extent, it's so important to learn how to compartmentalize the impact, the positive impact that you're having, even if it's on one person. Like sometimes we concentrate on numbers, right? Like, but one person can take the time to message you, to verbalize to you that, look, you made a difference and I appreciate it because I didn't have that or I don't have that. It's really important to take that and with intention quiet down the haters, because those voices can also get really loud
oh,
too.
it's intentional. I'm just ruthless at this point.
I love it. I love it. Have you always been this confident? Like, do you have you suffered from imposter syndrome, which I think is normal at different points of our life, but
For sure.
it can take over people's personalities.
I think I've always been confident, but I haven't always been vocal. I was much more quiet, I think, as a child. Um, Firstborn of four, immigrant parents. I actually wasn't born in this country myself. And so I was quiet, but I was always watching and I was always listening. And if anyone threatened my peace, I was always very good at protecting that. And I think I learned that just because my mom was a doctor, working, raising four kids. And then my dad was really like the OG feminist in my life. Three out of the four of us are daughters. His wife worked and he would be the one braiding our hair and packing our lunch. And then he would drive off to work. And so I just grew up in this highly secure environment where my mom was proud of who she was, had no problem letting people know, because she was of the first generation of people to really come to the States. So she had to defend her position at a time where it was far less common for Indian women to be working like she was. And then my dad defending his masculinity as someone who had daughters, proud of his daughters, braiding their hair, packing their lunches, dropping them off at school, and then heading to work because his wife was busy. So I think I just grew up in this environment where everyone was very unapologetically authentic. And so I was much more quiet. And then I found, I think very specifically, I think for me, a lot of my purpose came with my job and my kids, but I think my identity in that purpose, who I wanted to be as a surgeon and as a mother, really after I took my faculty position and had some rough experiences dealing with gender bias and having to make sort of a dramatic change to say, I'm going to leave this really secure environment where I'm employed at an exceptional hospital that's well respected. And I'm going to say that enough is enough and I'm going to leave. And it doesn't matter if I don't make a penny. I will do it because I need my self-respect and I need my happiness. And that was the first time I really had to make that kind of decision. Because in medicine, as you know, everything's very one step in front of the other, right? You just kind of follow the path. And I did, of course I had kids and some may say that that was unusual. And I got married young and some may say that was unusual. But I think leaving that paradigm and deciding to exit was probably the most unusual of things I did. And I really allowed it to define who I was going to be in my 30s.
So I hear that your purpose as a mom, as a double board certified surgeon, subspecialized. Let's unpack a little bit of your experience, if you don't mind sharing. It doesn't have to, we don't have to name names. We don't have to be specific to where you were, but during training, during attending ship, like what did you experience that was the turning point? Like, no, I'm done. Like, this is who I am, and I'm going to be vocal about it.
Absolutely. I have to admit, I decided not to be who I was for a lot of training because, as you know, residency is rough. Surgical training
Yeah.
it's a lot. And I was having children through it too. So I was having to already balance motherhood and then early on in my marriage with really difficult training. It's really a minimum of 80 hours you work a week. It's
Yeah.
easily upwards of 100, especially back when I trained.
Yeah.
And so I think I've already started noticing that little parts of my personality. I'm petite. I'm not Caucasian. I got married early and I married someone who was already established in medicine. So a number of times I would get comments like, why are you even finishing? Are you going to quit? I'll never forget my program director legitimately assuming that I was no longer going to apply for fellowship because I was married. Sort of surprised at our meeting. Oh, you still want to do plastics? Why don't you just stop here? Ravi can support you. Why would you need to do all that training? And you just, like you're exploding. You're like that cartoon character and like the steam's coming out of your ears, but you can't. You're like trained yourself to, well, I've really decided that it's my passion and I will, so you really tone yourself down because you have to. It's a survival mechanism. You gotta just get through it, right? And I did that. And then I think I did a lot of training, almost a decade. So by the time I got to my plastics training, I was a little bit more settled because I'd already had one child. I knew what I wanted to be. I knew what my passion was, but it was sort of a different set of issues, right? It was a different program. And it was, again, my husband also worked at that hospital. And just really, I found that my personality, my communication style, it was not what they were used to. And so, let alone trying to be who I wanted to be, I was trying to just get through it by being somebody that could just get through it. So I always say I have the most guilt with my second child because that was, I had a therapist my last year of plastic surgery training. And I tell everyone it's the best decision I made because it was so hard for me to deal with these people who were actively misunderstanding me, refusing to try and understand who I am and acknowledge the work that I can do. And when people challenge you and like skill set on that level, or your personality or your perseverance, whatever it is, and you're also raising an infant with another
Mm-hmm.
toddler. I mean, it
Yeah.
just shook my core in a huge
Yeah.
way. And so I um, went and I sought help for that to get through that year. And then I went into fellowship, and I think that's where I really found my pocket. I did my fellowship at UCSF, and I will scream it from the rooftops. They handled my third pregnancy and my fellowship with just such grace. And it was cool to be somewhere where people said, "Dang, Div, you are such a good surgeon. Like, we're impressed," or "You're doing a great job teaching the residents," or "You're so good that we're going to let you really take the reins on this case and let us know if you need help." And I went into preterm labor, and my program director called me knowing that I was rushing I was actually catching a plane back to LA. I was in San Francisco doing my fellowship while my husband was with my two kids in LA, and I would fly home every weekend pregnant. And
Oh
then
my
I
gosh.
went into labor, and I said, "Oh my God, I need to get the first Southwest flight out of here because I really wanted to deliver back home." So I got on a plane, and he calls
Why
me.
am I not surprised by you're like, water is broken. You're like,
I
I
gotta
gotta
go.
get
I'm like
back home.
at the San Jose airport doing, and I call my program director and I'm telling him, "Hey, like, not gonna make it in. Sorry. By the way, I think I'm in labor." And he was just like, "Hey, I don't want you to spend 1 ounce of your brain power or your energy worrying about this fellowship." And he said, "You graduated the day you started. You came in with this great skill set. We're glad we could give you what we could. We're grateful for what you gave us. I want you to have this baby, and don't you worry about it. We're going to figure it out." And it was just like the best. It was like such a
Yeah.
redemption arc for my training to end on that note. And it was, I think it was around 6 weeks early that I finished, and
Mhm.
it was, I couldn't make it to graduation because I had this infant, and all the like attendings and residents were texting me because he had made this little photo video montage of me and the babies. And in his speech, he said, "Div couldn't be here. She just had a baby, but I want to take a moment to talk about the fact that she has 3 kids, and she really was an example to our residents of someone who was really committed to her career, but also really committed to her kids." And it, like, I still tear up thinking about it because I
I'm
needed that
tearing up
redemption arc.
listening to your story right now. What an amazing person.
Yeah. Oh, he was so amazing. And all of my attendings at UCSF and plastic surgery were like that. And I think it was just it was only a year, but I always think about, man, what if I had that for all of my training? What if all
Yes.
9 years were like that? How much better would I have been because I was supported in the right way and allowed to really flourish? And I say it all the time, being a mom only made me a better surgeon. You really, the compassion, the empathy, and the time efficiency.
Yeah.
I feel like you bring
Yes.
so much balance to your life because every day you have these tiny humans that need you in every capacity. So I'm really grateful sort of for how that residency story ended. But my long-winded answer to your question is I didn't really find myself until after all of that was over because I didn't have the opportunity to be myself while it was going on.
Oh, thank you for sharing. And you had so many vulnerable moments in that story. So I appreciate, I know this is going to resonate with so many of our listeners, whether they're in medicine or not. So many jumps to take. Okay, so let me start from the beginning here. First and foremost, the fact that someone was willing to show compassion in the world of medicine. Again, back when we all trained and still present now during training, a lot of it is this trickle down from I went through, kind of a shit show experience. Therefore, you are going to
Hmm.
go. It's like this rite of passage, right?
Totally,
Regardless
totally.
of what
It's
residency
hazing,
training it is. It is
but
a
like
form of
10 years of
hazing.
hazing.
Yeah, yeah, it can really take a toll on your mental health. So I'm so relieved to hear that one, you engaged in therapy, but two, that you're open about it too, because I also firmly believe in professional help if and when needed. Honestly, everyone needs a therapist. I think it's good to
Everybody
just
needs
like
it.
bounce ideas
Yeah.
back and
If
forth.
and when is like yes and today.
Correct. That needs to be a slogan. Um,
Yeah.
but I think it's really important for us, regardless, us as women, to also pass along that same compassion, the benefit of the doubt, and especially in our brown culture, stereotypically, there's a lot of judgment. And when we judge others, we also harshly judge ourselves. And then when that trickles into the field of medicine, when oh, you're having a baby during like the one of the hardest residency, like what are you thinking? Oh wait, you're having another baby? Like why aren't you just waiting? Or wait, you're furthering your training? Why, when you can just stay at home while your husband quote unquote takes care of you? All of these old antiquated ways of thinking continues to be confirmed when you are also surrounded by a certain cultural aspect. So I think it's so important for us to continue to kind of break that pattern of thinking, and we can all rise together, like regardless.
Absolutely. But I think one of the biggest missed opportunities that I always talk to, just to my buddies about is, we are so good about bringing that rhetoric into raising our daughters and talking to our mother-in-laws and talking to our mothers and our sisters and women. Like you said, we gotta do it for us as women. So we gotta train our brains to look at things differently. But
Yeah.
we also gotta train the men because
Correct.
what has happened
Yep.
is that there has been a miseducation of men. We have grown up being told, my dad told me, you can be anything you want. You don't need your husband's money. You're going to do it all. You want to be a mom, be a mom. You don't want to be a mom, fine. You want to have a career, great. You want to have another career, great. You want to start another business, go for it. All of that has been told to me. But what I constantly talk to my partner that I operate with in the operating room is a male, and of course, my husband. I always tell them, were you raised being told that the women in your lives are likely going to do everything? They're going to be at home and they're going to be at work. So you need to be at home and you need to be at work.
Mhm.
There is a miseducation of men. And now you are seeing this major influx of women and our daughters who are growing up seeing moms do it all. But we don't have to do it all. We should share that responsibility
Absolutely.
with men, and they need to be raised with that education. Just like we were raised, you can be a mama and you can also work. They need to be raised, you can work and you can also be dad or uncle
Mhm.
or brother or whatever it is.
Whatever.
And I think
Mhm.
that is where I really would love to see us push the needle, is in the repairing of this miseducation of young boys and men. Because my husband is he has a brother, so two boys, and his mom has, to this day, like works tirelessly for their happiness, right? Just constantly making sure the household was taken care of. And she also worked and, being there for the grandkids and whatnot. And that said, she really took care of everything for them. You know what I mean? Like everything. And I felt like a lot of, when I was in residency, I think even my husband is like the consummate feminist in many ways, because now once did it come out of his mouth, I don't want you to do that fellowship, or do you really
Yeah.
need to do a second fellowship, or do you? No. He put his career on hold for me, followed me all over the United States, lived in a different city while I was pregnant with my third, raising my first two, right? So all of that was there, and I'm grateful for all of that. But the piece that we keep working on is, it doesn't have to just be me who goes to back to school night. It doesn't just have
Yeah.
to be me who volunteers for the field trips. I don't have to be the only one who plans the birthday parties. I don't have to be the only
Mhm.
one who goes to the birthday parties, right?
Mhm.
These can be shared responsibilities. And I think the more that we do that, the more we can, again, reverse this miseducation of the young boys. I posted on Instagram recently, I loved this reel I saw, and it was, what's your quiet feminism? Like, what do you do for quiet feminism? And my thing is, when I'm in social settings with other school parents, I look at the dad and I go, what do you like to
Mhm.
pack for lunch for the kids? What are they
Mhm.
into these days? Just a gentle reminder that you can
Mhm.
also pack the
Yeah.
lunch.
Yeah. Absolutely. That's such a great call out. I think I so just for listeners, I have an episode with Sanjay, my husband, who also grew up very similarly to you, Divya. Very, like, I always say it as like the typical Indian household where, both working parents. Mom was more like the matriarch centered household. Dad cooked, loved what he did, and
Yeah.
they really did take a equal share of everything, household and kid related activities. I grew up in a very stereotypical traditional household. Dad worked, physician, supported the five of us. My mom, hardest job in the world, raised the three of us and ran the household, cooking, cleaning. I mean, the whole works. And so in my head, I had the thought process, I have to do well in my career, but I also have to do well as a mom and as a wife. I alone have to
Right.
do it
It's a
all.
singular. Yeah.
Yes.
But
And
it
so when
needs to
I
be
met
plural.
Sanjay, 100% it did. This is a partnership, right? And
Yeah.
so to break these stereotypical gender roles, even if they may not be as conscious, right? The subconscious too. I think Sanjay was a wonderful balance to that, to be like, you do you. When I told him, you know what, babe, like medicine's burning me out. Being in primary
Yeah.
care is a lot. I am on the forefront of a lot of things. It is my passion. It is my calling, but our modern medical system is also burning me out. I'm going to cut back and look, I found something else that I'm also passionate about. And he's like, yeah, you got this. Like, what do
Yeah.
I do? That being said, again, that subconscious of, okay, now you're quote unquote working from home a little bit more than being in clinic 5 days a week. Um, let's default a lot of the stuff to the person being home without outwardly consciously thinking of it. I also took on that role, right? I'm more flexible. I have more time. When in reality, I'm not just sitting on my ass at home. I'm working.
Yeah.
I'm
Of
seeing
course.
patients. I'm recording. I'm writing. I'm creating. I'm working on a business. I mean, that is no joke. So it was definitely a learning process for the both of us
Yeah.
to, again, undo a lot of this stereotypical, not even gender roles, just roles in general. Like it's okay for our male partners to be the point of contact for birthday parties, for PTA meetings,
I mean,
for
seriously, why
all the
is it always
emails.
the moms on the emails? It
Yeah.
drives me crazy. I talk about this all the time. Either put both parents on there or ask which is the primary contact. I'm a surgeon. So even though I
Yeah.
do tend to manage the social calendar for my family, I don't have time for your emails and don't call me in the middle of the day. I just can't answer
Yes.
that call because I'm operating.
Yeah.
But
Yeah.
it doesn't matter how many times I say it till I'm blue in the face. I will still always forever be the primary contact for all three kids for school.
Yeah. And so one year I actually, I switched our names. So I made Sanjay their primary contact.
Yeah.
Sanjay is a interventional pediatric cardiologist. So he's in procedures a lot. There's a lot of emergencies, very unpredictable schedule. Knowing that that second call is going to be me immediately, because most of the time
He can't.
Sanjay also cannot pick up the phone in the middle of the procedure. But a couple of times when I got called from Gia's school, I asked, did you call my husband? They're like, oh,
No,
no.
they don't
And I'm like,
look.
but he's the first point of
They don't
contact.
even look. I have listed
Shocking.
Ravi as the first contact since pre-K for all three kids. I have my oldest is in fifth grade now. Doesn't matter. They will call mom first. And these are all,
Yeah.
again, these are, I don't like to use the word microaggression because I think even the word aggression is a little aggressive, but it's all these
It's a little extreme. Yep.
little built-in nuggets in society.
Yeah.
And with time, I have no doubt, right, that too will change. But in all of this change, we're seeing this massive influx of change in women. I want to see the change in men.
Yeah, I think we are slowly moving towards that. And it also, I find myself in a little bubble here in Southern California where I am surrounded by a lot of involved parents,
Yeah.
both, and a lot of dads taking a primary role, taking a primary interest, being present, knowing what the kids like, dislike, what they need to do, what's, on the agenda for school. So it's really refreshing to see that's not the way I grew up. And I know that's not the community that a lot of people are in.
Yeah.
So hopefully that will slowly trickle into larger scale changes, especially for our kids. So, okay, let's move to your professional life here. For those who don't know, what sets you apart from like a run of the mill plastic surgeon, run of the mill breast surgeon? What is your niche?
So I am a microvascular breast reconstructive surgeon. which essentially describes the ability to do tissue transplantation, but in the same body. So take fat and skin from somewhere else in your body in women where you don't want it, right? Whether it's excess tummy fat or thigh or whatnot, and move it to the breast for an all natural breast reconstruction that does not utilize breast implants. I also do the whole spectrum of breast implant reconstruction, whether it's direct to implant, above the muscle, all those things. I do all of that too, and I do a lot of it. But what I think really sets me apart is the ability to offer the whole spectrum. Because there are a lot of people out there who are general plastic surgeons or maybe even cosmetic specialists, and dealing with the breast skin and the breast pocket after a mastectomy is a completely different gig than a straightforward breast augmentation. Then you have some people who are breast reconstructive specialists, but they don't do the all natural tissue reconstruction part. And what I've really been seeing, especially as social media is, and healthcare are really finding a lot of crossovers, there are a lot of these breast reconstructive surgeons getting on the internet talking about what they do and leaving out this really, really important part of breast reconstruction that is actually oftentimes the definitive solution. So I'm going to give you some examples. Capsular contracture, tight scar tissue that can form around the implant. A breast implant is a foreign body. It's like a pacemaker. You're going to put it in and your body's going to form a capsule around it. So whether a pacemaker or a breast implant, that capsule can be normal or it could be pathologic. There could be something wrong with it, meaning it's really tight, it's really hard, whatnot. Well, when that happens in the breast cancer patient, a lot of these surgeons that don't do flaps, flap being the term of the tissue that we move, they will just redo the implant, redo the implant, redo the implant. And what is so much worse is they will liposuction the abdomen or they'll do a tummy tuck without telling the patient that there is this whole operation that can use that fat instead of throwing it away to reconstruct the breast and treat definitively 100% the capsular contracture. Same thing with women who have had radiation. You had talked about that in the intro. And flaps are for everyone, but I really think the population that benefits from this option the most are women who have had or are going to need radiation. Radiation, I like to say, is the gift that keeps on giving. It is great for cancer therapy, right? It lasts 5 to 6 weeks, but the effects are lifelong. That said, it also has lifelong effects on the quality of your skin and your tissue and the collagen and elastin and fibrosis and all of those terms that we use that represent how well your skin heals and supports the implant. Well, if you have an implant outcome that didn't do so hot with radiation, really the gold standard operation is to use your own tissue. And it kills me. On social media, I'll see relatively well-known and well-respected plastic surgeons put out these videos and they will post their results. Breast implant revision in a cancer patient with a tummy tuck. And I can't help but wonder, did you give them accurate information? And the accurate part is really key there because they haven't done these operations in 10 years, 15 years since they did training. We're in a new era. When I do these, I'll never forget, I was at Cedars doing a bilateral flap and I finished before the plastic surgeon in the next room who was doing a breast reduction, right? 4.5 hours. We were done.
Quick. Yeah.
No corners were cut. We did the absolute best work possible, but I have a really talented co-surgeon who works with me. I have a team. We are set up to do these with maximum efficiency. Patient didn't go to the ICU. They went home in 3 days. So these misconceptions about what microsurgery is are propagated and perpetuated by people who don't do it, if they even choose to talk about it, as they are educating the masses. And the problem becomes augmented because there aren't a lot of people like me. A lot of people finish plastic surgery training and they go, well, that was 8 years of a long time. I'm done. I'm going to head out and I'm going to open up shop and I'm going to be a cosmetic surgeon. Well, some of us decide to do the additional training for microsurgery, and there aren't many of us who choose to do this. So we're now, a small group of us are battling the misinformation provided by a large number of plastic surgeons, which is why I'm so grateful that I get to be on podcasts like this, because it's really important that women just know to ask.
Correct. Yes. Yes. The more options you know that pertain to you, the more educated, from a patient perspective, the more educated you can be. Even from a physician perspective, as a primary care doctor who I literally on Wednesday gave out 3 phone calls to my patients: breast cancer, and thyroid cancer. As a primary care doctor, patients depend on me to formulate their team when it comes to anything, any disease process. And so to know this educational portion of it that even I was not aware of during training. After I got into practice, you start learning about all the various options for all the
All the
various things.
things.
But specifically for this, right, when breast cancer specifically, is already pretty devastating. We're noticing patients at a younger age not only being screened more often, but being more aware about their genetic risk factors and just being diagnosed and just knowing earlier what is going on and going in for the appropriate treatments. And so to be in a position to counsel patients and to give them the resources and have them make the decision with their specialized physician, I cherish that role. And so I think it's important to even educate your fellow doctors and,
Yeah.
the people who are at the forefront kind of giving away these diagnoses and helping their patients formulate their team for further specialized care. So when a patient is diagnosed with breast cancer, they decide to move forward
Yeah.
with a mastectomy. Why is it important to find a good plastic surgeon for reconstruction and to know all of your options? You had touched on it with your explanation, but what are the pros and cons, for example? Like, why can't I send someone to a plastic surgeon?
I think, a lot of this also plays into the way healthcare works in the United States and what kind of plan you have and what group you're a part of and who you see. I will say, though, one of the biggest misconceptions is if you're part of a group, like say you go to UCLA or say you go to Cedars, it
Mhm.
doesn't mean that every doctor of yours has to be in that group. Now, your insurance
Right.
plan may be an HMO that's linked to one of those institutions, and that can be limiting. But especially if you have a PPO, you can go see whoever you want. You can make your little Avengers team, right? You can pick an oncologist from here, a breast surgeon from here, a plastic surgeon from here, radonc from here, and you can create the team that you're comfortable with. So the first thing I tell patients, you get to choose. So choose the doctors that make you comfortable. Just because somebody referred you to someone doesn't mean that you're stuck with that person. That's number one.
Correct.
Number two, the breast surgeon and the plastic surgeon work together. So you do want to make sure that who you choose is a dynamic duo. So you may
Yes.
see a breast surgeon that you like a lot, and they may send you to a plastic surgeon that you did not like. So you can either feed back to your breast surgeon and say, I didn't like option A. Do you have an option B or C? Or do your own research. And so I will have a lot of patients come to me and they may not have even chosen a breast surgeon yet. Or they have a breast surgeon that our privileges don't cross over at the same hospital. And I'll say, well, I don't know about that surgeon, or I'm unfortunately unable to work with that surgeon, but here's who I work with. Why don't I send you to one of them? And so we can curate your team for you in a way that you're able to achieve your goals. We do live in a bubble in Southern California. We've got plastic surgeons that do everything, but a lot of people don't have access. So, I have this breast surgeon I work with. She's in Bakersfield, and she's oftentimes limited with options of plastic surgeons who are working the day that she needs the case done, or maybe doesn't know how to do flaps. And she reaches out and she says, I have this patient. This is the day I have them booked. What can you do? And we time it so that, yes, they have to go flat for a couple of days, but they come to me and I reconstruct them real quick. And so we take advantage of the skin before it shrinks down or contracts or scars, and they still get a beautiful reconstruction. So there's so many paradigms in which you can get the reconstruction you want. But step one is you have to advocate for yourself. You have to be able to put your foot down if you don't like who you're seeing or they're not giving you the options that you want. And number two, I really, really believe in informed decision making and shared decision making, meaning someone's got to employ you with the data and the information, and someone's got to help you make that decision. The decision is ultimately yours, but you gotta fit both of those pieces in there. So things like this podcast, getting good information, not every online forum or website is good information, but there is good information out there from reputable sources. So be an information gatherer, and then feedback what you learn to your team and see how they respond to it. Hey, you offered me implants, but I read about this awesome option that involves tissue, blah, blah, blah. What do you think about that? And you're going to get one of many responses. Either, oh, that operation takes too long and this and that, the next thing. Well, then you should follow with, well, do you do that operation? How many do you do a week? And if they don't do it, or they're answering your question with how many they do a month or a year, they're not an expert. They're not the ones who should be giving you information on that operation. But say they do implants.
A little clue for patients.
Yeah.
When a physician or any clinician is unable to say, I don't know, but I will find out for you, red flag,
Such
like
a red flag.
huge red flag.
Such a
Sorry,
red flag.
continue.
No, totally, totally. And if they, let's say they're an implant expert and you really like them, well, you should go meet with the microsurgeon to hear all your options. That's the information component. And then you share that with the surgeon that does the implants that you like. And maybe you choose to get implants and you go with that surgeon. That's okay. But you made that decision knowing what the alternative is. What is so devastating
Yeah.
is how many women make a decision without knowing what their alternatives are. And that is hard because now you're constantly playing catch up and you lose a little bit of trust. And that's
You
really
do.
hard
And
too.
that's more long lasting, really. I don't know if you can answer this, but what options do HMO patients have?
Yeah,
Obviously, they can pay out of pocket,
sure.
but for those who are tied to specific medical groups, specific doctors,
Yeah.
what are their options if they do want to go, if they do feel more comfortable out of network?
Yeah. One thing I do for my patients who come to see me with an HMO, every plan has to be able to provide you the standard of care, right? So if you have a radiated breast and say you lost the expander, you lost the implant, and you're flat, the standard of care is to use all natural tissue reconstruction. And if that cannot be provided to you of an adequate quality within a certain geography within your network, the insurance company is obligated to then cover you going out of network. Do they make it easy? Lord, no. I mean, paperwork on paperwork, phone calls, dropped calls, all the things. You
Yeah.
will be, but we figure it out. So I've had a lot of HMO patients where I'm still able to do their surgery and they don't pay. I'm able to work it through a gap exception through their plan because I'm providing something unique. So that's always an option. Also, just because the provider is out of network doesn't mean the facility is out of network. So oftentimes,
True.
I always work at in-network facilities so that if there is an out-of-network component, it's only my costs. And even that, again, I'm usually able to work it through a gap exception or an LOA. But in those rare situations I'm not able to, the financial burden is restricted to the surgeon's fees and doesn't carry over to hospital stay and hospital fees, which is really helpful.
That's a really important piece of information to know. And also, as the patient, it's okay to feel empowered to question
Yeah.
the system that is so broken and convoluted. And even your clinicians are are really going through obstacles to get things done for their patients. But it's okay to ask questions. Let's move to screening. So by the time this airs, it's going to be Breast Cancer Awareness Month, the month of October, also my birthday month.
And
Woohoo,
my
yay.
birthday month. Are you a Libra?
Oh, you're a Libra?
Yeah,
When's your
October
birthday?
2nd.
First. We just found out something
This all
new
makes
about
so much
each other.
cosmic sense right now.
It
There's so
totally
much
does.
cosmic sense in this moment right
I'm
here.
dying right now. Oh, we're gonna have to do a whole separate personal
Yeah,
conversation
for
about this.
sure, for sure.
um, breast cancer screening.
Yeah,
There has been one changes
so
in
many.
recommendations, so much stuff out on social media. Obviously, as a primary care doctor, as a breast cancer surgeon, we know the norms, we're keeping up with guidelines. But for the patient, for the listener who's like, I don't know what the hell I'm supposed to be doing. What am I supposed to be
Yeah.
asking? Who am I supposed to be asking? Let's go over just the current, this
I'm
may
gonna get
change,
like
but the
cozy for
current
this. I'm gonna
screening.
sit
Yes,
Indian
let's do it.
style.
Fold up the
Yeah,
legs. Yes, yes,
we're gonna
yes.
get into it.
What is the current guideline for breast cancer screening for someone with an unknown or with no family medical history of breast cancer
Sure. So even this
or
recommendation
gynecological cancer?
keeps changing, but there is a literal task force that is given the duty of figuring out when do we screen people. And it's important to know where they come up with these recommendations to then contextualize the answers. So basically, it's like two curves and where they intersect, right? How many lives can be saved and how much money are we saving? It's a financial thing. It's also sort of a sociologic global health thing. So we want to save as many lives as possible, but we also don't want to make it so expensive. If you're screening a 20-year-old and not that many 20-year-olds get breast cancer, then they have to decide, quote, is it worth it? And this gets tricky because for us as doctors, every life saved is worth it. So we're also battling that, right? But the task force makes these recommendations. And today, in 2024, can't speak for tomorrow because it changes. Any woman, I believe it's 40 to 74, 40 being the age that they recommend you start. Here's the thing. Rates of breast cancer are going up in younger individuals. It's possible that it's genetic, it's environmental, probably a combination of the two. Number two, and you said this earlier, women are coming in far more empowered to engage in conversations regarding their family history. So women are coming in ready to talk about their risk factors, and there are family risk factors. There's your own personal genetics, and then there's your life, right? How many kids have you had? When was your period? Birth control, hormone replacement therapy, whatever, all those things. And so one thing I really recommend to everybody is have a conversation with your gynecologist or your primary care doctor about your family history. Whenever your next annual physical is, which get your annual physical, you got to take care of you.
Yes.
Get your physical.
Reminder, annual means yearly, friends.
Yes.
Yearly. I don't want to spend 2 years without seeing your face and you're just like, oh, has it been 2 years? Yearly, friends.
You got to take care of you. So do that. And I want you to put it in there that when you go in to see your doctor, you're going to have a conversation about, can we talk about my family history? Because it's not just breast cancer. We want to know about prostate and lung and colon and all of the things. And if there are any triggers, and we have a low threshold for a trigger, you know that, we're going to send you to a geneticist or a counselor, and they're going to put all these things into a calculator, and they're going to give you a risk. And that number is going to help you decide what you need to do next. So 40 at a minimum, but what I think is almost as important, if not more important, is in your 30s, in your 20s, engage in these conversations with your doctor, whether it's your women's health provider or your primary care provider. Engage in this conversation early, because the more you know, the more you can be prepared. And with breast cancer, it's one of those things, we have the ability to catch it early. And when it's early, it's just so, it can be a blip on the radar. A blip on the radar treatment. Exactly. But the minute it gets to a certain size of a certain type, now we're talking about really life-altering treatment plans. And we would love to keep this to just something small if we can.
Yeah, and great call out about the family history. As a primary care doc, that is something that I routinely review at every one of my patients' annual physicals. Have there been any changes in family medical history? This is what I have down. I mean, the power of the electronic medical record system, right? Everything I write down or anyone else writes down stays there. So thankfully, I don't have to review everything every single solitary visit. But for the annual physicals, have there been any changes, cancer changes? If there are any new diagnoses in between the time that I see you, email me, let me know, update me, because that may be a red flag in my head to when to screen you outside of the normal guidelines: colon cancer, breast cancer, cervical cancer, lung cancer. There are so many. And even if there isn't a pattern of one type of cancer, I know patterns. Your doctor should know and recognize patterns: thyroid, pancreas, breast. If there are certain patterns that are trios or put together, again, it'll kind of pull off a red flag in our heads to make sure that you get all the resources, especially genetic counseling. I send so many patients to genetic counseling just because sometimes I'm like, I don't know actually what to do. There is no guideline.
Same, because I am a breast cancer surgeon, and of course I deal with that as someone who's always doing the reconstruction for these women. They sometimes, again, come to me first, and I have to ask them questions, or women who have the BRCA mutation and they come to me, but I still, knowledge is power, and we're all so subspecialized these days. I can't possibly be a geneticist too. So I actually make sure they've all officially met with a geneticist or a genetic counselor to go over it, because we're constantly also discovering new patterns. And there are also little blips on the screening test that, one's like variant of unknown significance. Literally, that's what it's called, right? VUS. So we don't know is what we're trying to say, but maybe they know a little bit better than I know. And you can't start that process, like to meet with all the right doctors, until you do step one, which is talk about your family history.
Yeah, absolutely. And it could even not only get you screened earlier, but even more frequently.
For sure.
And so, we could incorporate, if needed, if indicated, according to your family and personal medical history, we could even alternate mammograms and MRIs of your breast every 6 months when we're specifically talking about breast cancer. For colon cancer, we could get you screened earlier with a colonoscopy. I mean, these are life saving
Life-saving.
imaging and procedures that we could do that could change the trajectory of your life. I mean,
Yeah.
I don't want to sound dramatic, but
It's
that's how dramatic
dramatic.
it can
No, it's
be.
dramatic. I am that dramatic about it all the time. Absolutely. It's how frequent, it's the modality, and now everyone's talking about dense breasts, right? Because recently it
Yes.
became required, legally required, that a woman who gets her mammogram is told whether she has dense breasts. So step one, you gotta
Yes.
get your mammogram to know that you
Ugh.
have dense breasts. So everybody get your mammograms. But then you are
Yes.
given this information, and it's like a now what? Well, dense breast, essentially it's a ratio of the amount of fatty tissue in your breast to actual breast tissue. So if you have dense breast, that means you have way more breast tissue than fatty tissue, and that appears a certain way on mammograms, and it can obscure
Mm-hmm.
newer, smaller cancers or certain types of cancers.
Mm-hmm.
Um, so because you now have more breast tissue, and it is the breast tissue cells, it is those cells that then become cancer, your risk of breast cancer is slightly higher, and our standard modality may not be enough, right? So
Yes.
take that information and then again feed it back to your provider. Is this enough? Do I need
Yeah.
additional ultrasound screening? What about an MRI? Those are all good questions to ask. And if you feel like you're not getting the answer that you want, if you feel like someone's not listening to you, see somebody else.
Correct. It is always okay to get a second opinion.
Always.
It is always okay to switch providers. I think there's this like I don't this guilt
Yeah.
of being like, oh, well, they're the doctor and they should. It's okay to question your doctor with respect, with compassion, obviously, but it is also okay to listen to your gut instinct and say, ooh, this person is not answering me. And remember, I don't know, but I will find out is an okay answer because we are human and we don't know everything. And as you mentioned earlier, some of us are so subspecialized that we may not know information about, other parts of your medical health, but we can find resources for you
100%.
to help you gain
I mean,
information.
I'm all the time saying, do you want a second opinion? I've got a friend who
Yeah.
might be able to present the information in a different way, may have a different opinion. Do you want to meet with them? And that's a green flag for a doctor, I think, just when they
Absolutely.
are willing to collaborate or send you to somebody else, because
Yeah.
we're all human. We're all just doing the best we can. And it really is, your health is a partnership. It doesn't all fall on your doctor. It's
Absolutely.
you as well, but you're mutually
100%.
responsible for maintaining your health. And so that is getting the right information, feeding it back, listening to advice, seeing a second opinion if you need. It's all these little steps. And you can, of course, engage in a mid-course correction. If you feel like you're going down a path that doesn't make sense for you, correct.
Yes, yes. So let's go back to dense breast tissue because that's all the buzz right now. So it is pretty well known that younger patients have denser breast tissue. One of the reasons why we don't do mammograms in a otherwise healthy, no family, strong family medical history 20-year-old, we're not doing mammograms in them because the pros and cons really don't balance each other out. But for the run of the mill, 40-year-old woman that comes um, in my head, I know she has dense breast tissue. In my head, I also know the rates of breast cancer has gone up in younger patients. I automatically order a 3D mammogram. This was before all the buzz came out about dense breast tissue and what you should order and what you shouldn't order. Is that something reasonable that patients can ask their primary care or their gynecologist? Like, I would like a 3D. I want a whole breast ultrasound in addition to the mammogram. Is it okay to ask for all that, knowing what we know?
I think so, absolutely. This is a little bit outside of my wheelhouse because I'm not a breast radiologist. And I know that there are different types of um, mammography, there are different types of MRI,
Hmm.
even, and ultrasound. Those are our three main modalities that we use to evaluate the breast. So I always say if you have family history, if you feel something and the
Yes.
result is negative, no matter what, dense breast or not, challenge it. Especially
Yeah.
if you have a dense breast, challenge it. And you can
Yes.
ask for additional imaging. Now, what that additional imaging
Yeah.
may not be a 3D mammogram. It may be something else. It may not be the ultrasound. They may want to go straight to MRI. Um,
Yeah.
but definitely bring it up and challenge it. And if you don't feel comfortable, if you're not getting the answer you want, ask again or see someone else. The biggest challenge is
Second
getting
opinion.
insurance to cover it. We're getting better and better at it. I write letters
Yes.
all the time for women. Um, I think if, again, personal opinion, this is I'm speaking a little bit outside of what is in the box of absolutely true. But if I have a young woman and she has a breast cancer and she's having breast cancer surgery, I don't see why she shouldn't get an MRI of the other breast. Shouldn't we
Yeah,
know if something's brewing in there? And you'd be surprised
absolutely.
the number of times we
Absolutely.
find something. So we're catching up,
Mhm.
right? We've known this stuff about dense breasts for a while. Now legislation has caught up. So I think insurance companies are then, that's the next step, right? They're now going to be held accountable
Yeah.
for this information and what women need to do about it. But absolutely, you should ask for more imaging. What it is, I don't know. It may vary based on your age, how dense your breasts are, your family history, your personal history, but additional imaging absolutely makes sense.
Yeah. And if you feel something in your breast as a patient and you go to your doctor and you were told to ignore it, not follow up, not get imaging, all of the above. Now, I do want to, I know it hurts your heart. It hurts mine too. I, I think depending on depending on a lot of factors, let me just say this, depending on the what you're feeling, if it comes and goes, a physical exam, if it goes along with your cycle, um, sometimes it's okay to wait a menstrual cycle to see the pattern. If the mass is there, it's fixed, it's hard, it's painful, there are skin changes. I mean, I've had patients come to me saying, I was told to wait this out. And those are just very obvious red flags. You need, at minimum, you need an
An
ultrasound or
ultrasound.
some sort of imaging at minimum. And
Yeah.
even if the physician, even sometimes when I don't feel it and the patient's like, it's there. And I'm like, I don't quite understand. But look, it's hurting you and it's been there for a while and you're bothered by it. And ultrasound is a non invasive modality to just take a look and to at least put a lot of uneasiness at ease temporarily. Now, if we need to do further workup, that's fine. But it is imperative that you bring this stuff up to your doctor. You learn how to do a self breast exam. You, as the patient, know your body's the best. We see you once a year, if then,
Yeah.
if that.
Yeah.
And so, if you feel something that doesn't feel right, that is different for you, again, this is a partnership. You got to let your doctors know.
100%. There is no excuse for ignoring any breast mass, in my opinion. I do think waiting one menstrual cycle is the maximum of appropriate. I get it. There are a
Maximum.
lot of, yeah, because there are a lot of hormonal cysts and whatnot, especially in younger individuals. Fine. But no one should be telling you to wait more than that, ever. And if you still have it, there is no excuse for, at a minimum, getting a mammogram with an ultrasound. And here's the thing about
At
mammograms,
minimum.
especially, is that they're all relative to the previous one. So you got to keep up with your mammograms to make the most of your spot checks if you do feel something, because they're going to want to compare it
Yeah.
to a previous image. And say you get it
Yeah.
done and you get the mammogram and you get the ultrasound and it doesn't feel so right. Ask for more imaging. Say, can I get an MRI?
Hmm.
I still don't feel
Mhm.
okay with this. That will definitively put it to
Mhm.
rest, plus or minus a biopsy. Now,
Yeah.
I don't want to like create fear mongering and stress. And I'm not saying that,
Yes.
some women have dense breasts. I do. There are
Mhm.
fibrocystic changes, there's fibroadenomas, there's
Mhm.
a whole list of benign non cancer masses of the breast. So if you biopsy and you know that's it, that's pretty good. But you want
Yeah.
to monitor for changes. Is it growing? Is it shrinking? Is it moving? Is it,
Mhm.
like you said, fixed or hard? Am I noticing any
Mhm.
lumps in my underarm? It's everything that you do with evaluating your breast is relative to what it was before. So you got to start
Yeah.
and you got to keep up with it for you to then get the most impact of your self exams and your mammograms. But if you have a
Yeah.
breast mass and someone tells you to wait any more than just a singular menstrual cycle, that is incorrect information. If you have a breast mass and it is not going away and they are not actively imaging it, that's a problem. If there is a mass and you're worried about it and you're asking for a biopsy or this or that and they're just saying you flat out no, go see somebody else.
Yeah, I agree. And I know insurance companies can, they go by a certain algorithm, and we understand that there are guidelines for a reason, right? And so it's important from our end to kind of balance out the guidelines and the patient in front of us. Clinically, what am I seeing? And clinically, what is the patient experiencing that it may not follow the textbook? Most cases don't
They
actually.
don't. And I always like to
So
ask, what's the worst
mhm.
case scenario, right? Like, there are certain things you
Yes,
should
so you
never
find
roll
out
the
more
dice.
information.
Yeah, don't ever roll the dice with breast cancer. It's just not worth it. Don't do that.
No, Well, that's the greatest ending to this podcast ever. Don't ever roll your dice with breast cancer. I mean, it's not worth it. Dr. Divya, thank you so much for joining us here on the Beyond podcast. There were so many gems, everything from your origin story and how to overcome imposter syndrome, what helped you, what support looks like, all the way to breast education, which is, again, such an important part of your work. Where can people find you?
So I practice in Los Angeles and Austin. So theiabr.com is the practice website, theiabr.com. And that'll have links to all my office locations throughout Los Angeles and in Texas. And Instagram, my handle's at Dr. Dhivya Srinivasa. Come see me in person. Would love to talk about things with anything related to breast cancer, breast reconstruction, or you can laugh along right with me on Instagram.
That's what I do. We will post all of that information in the podcast information page. That way you guys can just simply click on it and go to all of Dr. Divya's resources. Again, thank you. I appreciate your time. I know you're a busy woman. Thank you for being here. Really appreciate it.
Absolutely my pleasure. This was so soul filling. It filled my cup to talk about these things. So thank you.
I know. It's a great way to start off our Saturday morning. All right, Beyond listeners, I want to hear from you. Dr. Divya wants to hear from you. DM either one of us through Instagram, email. We have resources all on the podcast information page. And then coming soon to you all is a YouTube page. So you will be able to watch this on video. Stay tuned. I will be giving you guys updates, but we'll see you guys later. Thanks for being here. Bye. Thank you so much for joining and spending your precious time here with me. As someone who prioritizes her energy, I am so grateful that you chose to spend yours here. To help me help you, please take an extra 30 seconds of your time to rate and review the podcast on your listening platform. For more tips and a behind-the-scenes look into my life, follow me on Instagram at Dr. Flora Sinha. That's Dr. Flora Sinha. Finally, connecting with you truly fills my cup. So DM me on Instagram, email me at florasinhamd@gmail.com, repost if you loved this episode. I love hearing from you. I am so grateful for you and cannot wait to be back for the next episode. Bye.